Thank you so much. I think you guys can hear me. Okay. Thank you so much, everyone, for being here, for your amazing engagement and attention. And thank you to our panelists. I'm very honored to be here. I've learned a lot today. You may be able to see my notes on the back of my paper. With this final panel, we'll be delving into one of the most defining aspects of women's health, and that's hormones. Hormones are impactful to our lived experience as women, whether it's during puberty, during pregnancy, perimenopause, and the menopausal transition. So that's what we'll be discussing today, and we'll be delving into how hormonal influences impact migraine and other related symptoms and conditions as well. We'll also talk a little bit about how we can approach our healthcare providers regarding these topics, because that can be another barrier to care as well. Let's start off with just defining how our hormonal patterns change across our lifetime. Dr. Shahab, could you start by talking about that a little bit? It works.
Yeah, did you want to start with the bigger picture? And
Sure. Yeah, I can talk a little bit about what happens to our hormones during our reproductive life. And so I will focus mostly on estrogen, because estrogen is the hormone that seems to affect migraine attacks. So when we start our menstrual cycles, which is menarche, we begin to have a natural rise and fall in estrogen. And this estrogen is produced primarily from our ovaries. And so as we, initially when we first start our menstrual cycles, they can be kind of irregular, but most times by the time a woman is in her late teens, we see a natural rise and fall to the estrogen levels, which account for our menstrual cycles. There's also a rise and fall that happens mid-cycle, which is during ovulation. And this pattern continues until pregnancy, which, at that time we have a natural rise in estrogen, and then it maintains, and there's a steady level of estrogen. And you may find, even personally, that maybe during that time you had a reprieve from headaches. And so that we see that when there's a steady estrogen level. After that, there can be when patients will start with lactation, there is a fall in estrogen, but it does remain steady during that time. Once menstruation begins again, there's that natural rise and fall. And this continues until a woman's early 40s, that is when they begin to enter perimenopause. And perimenopause, there's erratic rise and fall in estrogen. And this is another time that patients can experience a change in their headache patterns. And then we end up, and this leads to menopause, at which time there is a natural decline in estrogen, and it remains steady at that time. So I'll now pass this on to Dr. Shihab for some definitions.
Yeah, so the way I define menopause to my patients is that when you come to me and you tell me your last menstrual period was 12 months ago, so it's the cessation of this ovulation, the production of the mature egg, and this rise and fall of the hormones. On average, this could happen, anywhere between age 45 to 51, 52. Perimenopause is as we're going through these changes. So it's these transitional phases of menopause. And I describe this as a roller coaster. So if we would imagine we would have this natural kind of or smooth rise and fall in our hormones, which in reality, majority of us do not have this smooth, up and down of our hormones. In perimenopause, imagine that it could get really worse. So there's a lot of peaks and there's a lot of valleys, and sometimes the peaks are not high enough for us, and sometimes the valleys are too deep. And that's when a lot of us can start experiencing a lot of the symptoms and the changes. So the changes could be changes in your menstrual cycle, and that does not have to be going from regular to irregular, because we could start with irregular cycles to begin with, but it's the change in our pattern. So it could be heavier periods or lighter periods. It could be longer bleeding or shorter bleeding, or it could be longer intervals between your bleeding or shorter intervals between your bleeding. At the same time, that's when we can start experiencing symptoms. So I define this as perimenopause, and menopause is just a point in time. A lot of times what I see in the clinic is women come to me and tell me, well, am I in menopause or am I post-menopause? And it's really a journey. I say, well, let's not focus a lot on the definition and where we are, because this is a journey, it's a transition. We're going through this phase or season of your life, and we're here to support you. I don't care a whole lot about whether it's menopause, post-menopause, or perimenopause. A lot of times the treatment is really the same. I know it can give some relief to know where we are. We can rely on some symptoms and whatnot. Mostly it's clinical diagnosis, but just think about it, transition, and it's a journey.
Thank you so much to both of you for going over the physiology, especially of estrogen over our lifetimes, and then how we define menopause and the symptoms to look out for. Dr. Starling, can you tell us a little bit about how these hormonal changes can impact migraine?
Yes, of course. So some of it was already mentioned, but really kind of starting at the very beginning. In children, right, migraine can happen in children. 1 in 11 kids have migraine. In children, pre-puberty, boys actually have a higher prevalence of migraine than girls. That crosses at puberty because of the estrogen fluctuations, right? And so moving beyond puberty, there is a higher risk of migraine in women than in men. So 1 in 5 women have migraine, 1 in 16-ish men have migraine. And so it really kind of happens there. And so a lot of individuals who have migraine, women who have migraine, will start having migraine attacks around the time of menarche. And then, as was mentioned by Dr. David, it's not necessarily the level of estrogen, but it's the change in estrogen that can be a trigger for migraine attacks. I chose that word very carefully. It's not the cause, right? Migraine is a genetic neurologic disease, but there can be many triggers, right? Just like we talked about asthma, right? Dust could be a trigger for an asthma attack, right? Or allergies can be a trigger for someone who is having an asthma attack. Similarly, the change in estrogen goes too high, goes too low. That rapid change is what is the trigger. So around the menstrual cycle, there can be an increased frequency of migraine attacks. It can actually have more severe migraine attacks and migraine attacks that are more resistant to medications as well. And that typically occurs, the vulnerable time period is typically after that drop in estrogen, which happens prior to starting to bleed with your menses. But that's the vulnerable time period. And for people who have migraine attacks more commonly around their cycle, and even a couple attacks around other times of the month, it's menstrually related migraine. It has a whole separate diagnosis because there are treatments that we can use to address menstrually related migraine that are a little different, perhaps, than migraine without a menstrual component to it. And then there will be fluctuations that occur with the menstrual cycle and migraine attacks. In pregnancy, as was mentioned, especially once you enter that second and third trimester, although there is that increase in estrogen in the first trimester, and there may be an increase in migraine frequency in that first trimester, but once you get to that second trimester, about 80% of women, based on the studies, will have remission of migraine or much improvement of their migraine disease. Why that is so important is because there are studies that show that 70% of women who have migraine have not gotten pregnant or delayed pregnancy because of their migraine disease. Because they don't know what is going to happen to their migraine when they're going to be in pregnancy. And also, they may fear, or they may even been told, well, once you get pregnant, we're going to have to take you off all these medications that help you, and there's nothing else we can do. Take some Tylenol, right? And so I'm here to tell you that for 80% of women in pregnancy, there is improvement in migraine by that second and third trimester. And more importantly, we have many, many, many treatment options that are available for women during pregnancy. Okay, I'm going to pause there and let that settle in because I think it's so, so important. Now, as was mentioned, is if steady during pregnancy, but then there's a drop after delivery. However, if individuals are breastfeeding or lactating, that level actually is pretty steady. And there's some studies that show that breastfeeding or lactating can actually be protective of returning back to that prior migraine frequency before pregnancy. And so that's something I share with my patients as well, right? Because it can help them make other personal decisions, perhaps. And then people will return typically to that cycling where they'll have changes in estrogen and they may trigger migraine attacks. And then during perimenopause, right? In general, people think, well, I thought my migraines were supposed to go away when I'm in menopause, right? And it's all during this journey, there's actually an increased fluctuation, peaks, 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 valleys, 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 just changing rapidly. And that is why many of the patients that I see in my clinic are in this menopausal transition. And they come in because now their attacks are more frequent, more severe, more resistant to the typical treatments that they've had before. And they think something new has happened. Why am I having these migraine attacks now? And I'm like, well, but remember that you just told me that you had regular headaches throughout college where you'd rather be in a dark room that's quiet? Those were migraine. But greater than 50% of people with migraine have actually never even talked to a doctor about their symptoms. And so many of these women who are in that menopausal transition, they're presenting to the headache clinic for the first time because things are more frequent, more severe, et cetera. And then for some women, right, after it's low and steady, once they have gone through the transition and they're fully in menopause and their estrogen level is low and steady, that their migraine may improve or it may change, right, where the pain is less, but their nausea is worse. And so we still have to support women through those transitions.
Thank you so much, Dr. Starling, for walking us through that. And you were discussing how there is very vast fluctuations in the menopausal transition time and how that can greatly impact patients with migraine and result in more severe migraine attacks. Dr. Shahab, can you talk a little bit about the variety and burden of symptoms these patients experience that you see?
Yeah, so I think about it as twofold. Like Dr. Starling said, well, what happens to the migraine disease? So either new onset migraine around perimenopause, again, because of that fluctuation in the hormones and the sensitivity of the body, intensity of the migraine, the severity of the attacks, the frequency of the attacks, the new symptoms or the resistance to the treatment. But also think about what's happening in perimenopause and how can that be part of the migraine disorder itself. Or just the perimenopause. So hormones, we need hormones head to toe. So our perimenopausal symptoms can be head to toe as well. So think about it head to toe with the migraine disorder. So hot flashes and night sweats, we call them vasomotor symptoms of menopause, but also sleep disorder, the change in our sleep quality, the sleep interruption, we're not able to sleep, we're waking up not feeling refreshed, then we're waking up very tired and fatigued, change in mood, there's anxiety, depression, restlessness, change in our resiliency. So we've managed maybe stress and symptoms before, and that stretch band, we would stretch it and recoil, stretch it and recoil. And then I always say, well, that band is way too stretched right now, and it doesn't recoil. So our resiliency goes down. So our stress management and how we handle stress and multitasking and caregiving for children and family and jobs and all of that, now we can no longer handle it. So sleep quality, fatigue, the mood changes. An important aspect I want to mention is brain fog. So a lot of times I see patients because of brain fog and perimenopause, and then we try to do the hormonal management and talk about the sleep and talk about the mood, but that could be part of untreated or uncontrolled migraine disorder because that can cause brain fog. So we have to think about it that way. As in the earlier panel, we've talked about the autonomic dysfunction. So the orthostatic intolerance and the palpitations, I always joke with my patients, everyone almost sees every other specialty before they come and see us to talk about hormones. So a lot of times women are seeing cardiologists for the palpitations and the awareness of the heartbeat and the lightheadedness and all of that. And very well so, they've had all the cardiac workup, which came back normal. But then they're like, oh, maybe it's your hormones. And it is. We see a lot of palpitations or awareness of that heartbeat because of the hormonal fluctuation. And if that's part of your migraine disorder, then that could be on steroids as well. So that could get worse. So I see it as a twofold. Then if you combine all of this, then the quality of life really goes down. So there is this sense of, I'm not feeling well, this well-being, like I'm not myself. We hear that a lot in the clinic. I just don't feel well. I don't know what's going on. So the well-being and the quality of life is really impacted. And I know we'll talk about sexual health too, because that's part of it as well.
And I just wanted to add, we've been talking about the ictal symptoms, the symptoms you have during an attack. And then we've been talking about the interictal symptoms, or the symptoms that you have between the attack. And a lot of these symptoms that Dr. Shahab has mentioned, a lot of them are present just all the time, right? And so often people are like, well, but how can some of this be migraine if it's just all the time? But this interictal burden of symptoms is definitely very present in this perimenopausal population. I mean, there's a lot of studies that have been done about the interictal burden, but we should do one specifically in perimenopausal women because I suspect that it is higher. That's what I see. And the other thing I'll share too is there's this really interesting study that was done. It's called the Overcome study, where they looked at a lot of different aspects of migraine experience in patients. And one of the questions that they asked of patients is, what is it that triggered you to finally seek care in your migraine journey? Because I just said 50% of people don't even talk to a doctor about their symptoms. So it's really important for us to know, well, what was it that finally was the tipping point that resulted in you seeking care? What would you guys think it would be? Just throw something out there. Yeah, so chronic, and I heard a couple people say like the pain, right? But and I thought so too, and I'm like, why are we studying this? Of course, it's the headache, right? But it's not. It was actually the interictal symptom burden. The symptoms that people have in between attacks, when that burden of symptoms rises, that is the primary driver of care-seeking behavior. And that was actually a huge changing point in my clinical practice where I really started focusing a lot on that interictal burden, because I now understood, hearing from that study, hearing from patients, that is actually very disabling, and maybe for some people even more disabling than the attacks.
Thank you so much for answering the question and adding that piece as well, because certainly the interictal symptoms can be so incredibly impactful from a quality of life perspective. Dr. David and Dr. Shahab, can you talk a little bit about what hormone replacement therapy is and who's a good candidate for that in light of these symptoms?
I can certainly talk about hormone replacement therapy. So hormone replacement therapy, and actually I should clarify, we actually call it hormone therapy because in menopause, it's natural that you lose your estrogen. And so we aren't necessarily replacing something that's supposed to be there. So we call it hormone therapy. But typically when a patient enters menopause and after we do a risk-benefit analysis, we can then determine if the benefits are outweighing the risks and they are suffering from vasomotor symptoms, or they have a risk for osteoporosis, they would be a good candidate for going on hormone therapy. Typically, estrogen is what helps all of the symptoms, and so we will place them on some form of estrogen therapy. Typically, I like to use estradiol, which is biosimilar to what our body used to make. Then we also determine whether or not they need a progesterone. So progesterone is there to counteract the effects of estrogen on the uterus. So typically if a patient has an intact uterus, then we will give them estrogen plus progesterone. But there are many different types of estrogen that are available, that are FDA approved. And so this is a shared decision with the patient. Same thing, there are multiple different types of progesterone. So if it is a synthetic progesterone, it's called progestin. And we then determine what would be the right match for our patient. Most of my patients like to do something biosimilar, and I tell them that, hey, guess what? There are FDA approved products out there, estradiol and natural progesterone. And then we determine, well, how are we going to give it to them? What's the delivery method? For progesterone, usually that is an oral preparation, so a pill that they would have to swallow. But for the estrogen or estradiol, there's multiple different formats. There's transdermal, meaning it can come in a patch, it can come in a gel that you can put on your skin. There's a foam that's available, there's a pill, there's a vaginal ring. Most times we recommend doing transdermal therapy, meaning going directly into your skin, because the observational trials have shown that there is a lower risk for stroke. And we all are concerned about that, right? So most times I will tell my patients that is my recommended route. And so those are the types of hormone therapy that we recommend.
And you mentioned weighing the risk benefits. You mentioned the potential increased risk of stroke as well. Dr. Starling, can you speak a little bit to how we weigh these risks and benefits for our patients who have migraine with aura?
Yeah, that's really important. So we have people who have migraine without aura. So what is aura? Aura are transient, meaning they are not permanent. They come, they go. They're typically 5 to 60 minutes, typically prior to the onset of having the peak of head pain. And they can be visual symptoms where you'll see like kaleidoscope vision, or sensory symptoms like numbness and tingling on one side of the body or the other, or even speech symptoms where people have an inability to produce language or produce words, or like word salad comes out. Sometimes maybe you've seen videos of this. There was like a reporter a couple years ago where it happened during a live broadcast. And this can occur, aura can occur in about 30% of individuals who have migraine. And in individuals who have migraine with aura, there is a twofold increased risk of stroke. We don't exactly know why. We have a lot of different theories, and it likely is a combination because of all of those things, because we have evidence for all of those different things. But we do know that there is a twofold increased risk of stroke in individuals who have migraine with aura. There is not an increased risk that we have found in those larger epidemiology studies in the large majority of individuals who have migraine without aura, although we do have some comorbidities with cardiovascular and cerebrovascular diseases just in individuals with migraine as well. But stroke, mostly migraine, aura, increased risk. And so as was mentioned, that estrogen can increase the thickness of the blood. And so because of that, it can increase the risk of stroke. And specifically during the time when people may use oral contraceptive pills, where it's additional estrogen, right? So it's not that estrogen is down during menopause and you're I forget it, using hormone therapy, I'll use the right terminology. But here you're giving exogenous estrogen or more estrogen. And so we know that the use of oral contraceptive pills with estrogen in it, so combined CHCs, that increases the risk of stroke in individuals with migraine with aura sixfold. And this is in women who are less than the age of 45, and definitely increased even further if there is smoking. Now, these are large population-based studies. These were also studies that were done a long time ago using doses of estrogen in OCPs that are not used in the US anymore. And we don't have recent studies that have looked at what about the doses that are used now. And then also it's looking at individuals who have migraine with aura, meaning you've had 2 of these aura episodes. And so there may be people who have had 2 of these episodes in their lifetime versus people who have aura episodes multiple times a week. Right? And there are some observational studies that have shown that the frequency of aura symptoms may be correlated to the risk of stroke. And so there's a lot of unknowns here. And so although currently the ACOG, American College of Obstetrics and Gynecology, still has the global recommendation, because I said US uses lower amounts, but not everywhere else in the world does. So the global recommendation is that estrogen-containing oral contraceptive pills are contraindicated, should not be used in individuals with migraine with aura. Now, for my individual patients, it's a risk-benefit conversation that I have with them, and I often will work with my women's health colleagues as well, because it's nuanced, as I've already told you. Same thing applies with hormone therapy in the setting of perimenopause and menopause, is that, number one, there is some data that shows that for at least a cohort of women, although hormone therapy can be helpful for some women with respect to migraine with hormone therapy, There are some women who will have worsening of migraine with hormone therapy. That's something that we have to keep in mind. Number two, we also have to keep in mind that if they have migraine with aura, they're already at a higher risk of stroke. Does the estrogen potentially increase that risk? And again, the transdermal approach versus the oral pill approach is better because the transdermal approach does not have that increased risk of thickening the blood as the oral estrogen dose does. So there are risks, but there are many benefits, and it really is a nuanced conversation that needs to occur between the patient, the clinician who's taking care of migraine, as well as the clinician who's taking care of the hormone therapy. So everyone needs to kind of be involved in this conversation. The other thing I would say too is that in many of these times we're like, okay, the benefit of being on hormone therapy or even in estrogen-containing OCP is outweighing the potential risks, and we initiate the estrogen therapy, but we counsel them that if there's a change in your migraine, or if there's a change in your aura, if now your aura is more complicated, longer, different, we need to know right away because we then may change the therapeutic approach. And the other thing that we may be getting to, but I just want to say in case we don't, is that there are many other ways that we can provide contraception. There are many other ways that we can provide treatment in the setting of perimenopause and menopause for the menopause symptoms and perimenopausal symptoms as well as migraine. So it's just communication, right? Because we can figure out a treatment plan that's going to be best for you and really have a good balance of that risk and benefit.
And I just wanted to add one more thing to what Dr. Starling said, which I thought was excellent. I have a lot of patients that when I see them and I really discuss what are the levels of hormone therapy when compared to oral contraceptive pills. And they are surprised when I tell them that menopausal hormone therapy doses are a fraction of what is in birth control pills. Even the lowest dose birth control pill, when I put them on hormone therapy, it is still lower. So in certain situations, the risk can be lower too.
Thank you to you both for going over those treatment nuances. It's really important to understand that risk, but also understand that it's individualized to everyone's lived experience as well. And Dr. Starling, thank you for segueing into my next question, which is going to be, again, directed at Dr. David and Dr. Shihab. Can you tell us about the non-hormonal options for management of symptoms during the menopausal transition?
Yeah, I can start. So I think about it, like you said, hormonal, non-hormonal, pharmacological, non-pharmacological. So let's say hormonal options are out either by preference or risk-benefit analysis. Non-hormonal prescription medications, I'll usually say, well, it's targeted towards your most kind of maybe bothersome symptom. I may not be able to cover all of your kind of perimenopausal experience, but again, let's pick what's debilitating the most, right? If there is a pain comorbidity, right? So we may pick one option. If it's mostly hot flashes and night sweats, we may pick an option. And then again, we would have to kind of go by their symptom and kind of choose together and have a good follow-up plan. I'm more than happy to go over details or mention some prescription medications. Now we have 2 FDA-approved medications to treat vasomotor symptoms of menopause, and vasomotor symptoms are the hot flashes and night sweats of menopause. These 2 medications work on the receptors in the brain that regulate the body temperature centers. We can also pick kind of maybe mood kind of regulating medications that can also work on the hot flashes, night sweats, but also help with the mood. That could be part of menopause, so we can pick those or other options. And then I always say, your body is not in isolation to what's happening with you in your environment, your home life, your work life, spiritually, right, mentally. So we should think about it holistically as well. So I talk about, well, how can we optimize your sleep? How can that be a priority? Again, if I'm, seeing someone with a migraine disorder, we know that there are multiple triggers, if you want to say, that could intensify or aggravate their symptoms. So we talk about sleep, we talk about stress management, what Dr. Townsend said about setting boundaries. Believe it or not, I talk about boundaries all the time in my clinic. And even though I'm not, a mental health specialist, so stress management, prioritizing your health, exercise, mind-body connection. We talk about mindfulness and meditation a lot. We talk about connecting body and movement, so yoga and Tai Chi. And maybe we don't have a lot of kind of evidence towards these, saying kind of number-wise and statistic-wise in research and controlling the symptoms. But trust me, you know, the worst thing that it can happen, it may not work super well for your hot flashes and night sweats, but you will feel better. Then we talk about acupuncture in treating the hot flashes and night sweats. It can help with sleep. It can help with pain, clinical hypnosis and hypnotherapy. That's also in our guidelines to treat menopausal symptoms, cognitive behavioral therapy as well.
Thank you so much. It sounds like the treatment landscape is very broad, and that's really empowering and reassuring to hear. I want to talk a little bit about sexual health, and so I'll transition over to Dr. Sobel. Can you tell us how sexual health and sexual dysfunction, what factors are impactful to those to that area in individuals, especially going through the perimenopause transition?
Absolutely. So when we think about sexual health, it really is a part of our health as women, as people. When we think about sexual health overall, there's 4 big components I think about when I see my patients. The first is libido or desire. The next one is arousal, both mental and genital. There's also orgasm function. And then there's pain, and specifically pain with sex, but also pain overall. And so when I think about looking broadly at women who go through this transition where their hormones are changing, and then eventually they're in an estrogen low state, all of those aspects can be impacted. So we know that there is a loss of libido or desire, which we can see. Unfortunately, there can be changes in arousal, both mental again and physical. Orgasm, the ease of achieving it and the intensity can decrease. And unfortunately, sexual pain can rise because of the loss of estrogen in the vaginal tissue, in the urinary tissue as well. So just broadly speaking about this transition, that can be really impactful. Now, we have absolutely great treatment options to help women, but I think when we're taking a step back and thinking why we're here today, after hearing the amazing other sessions, it's pretty impactful on our entire body what's happening in patients with migraine in terms of not only the body parts of the whole of what's changing, right? What is happening in terms of how we're looking at ourselves in the mirror, right? Talking about the impact not only of how migraine can affect our ability to eat the way we want to be eating, to move the way we want to be moving, right? To feel as good in our bodies as we want to be feeling, so that way we're interested in having intimacy or being naked with whoever we're going to be doing that with, even ourselves, right? Also, unfortunately, what is the impact of the medications that we're taking, right? There are amazing medications for many of the, the people here that can help decrease that amount of pain and decrease the way that you are living and suffering on a day-to-day basis. However, unfortunately, that can impact our risk of weight gain, which might not make us want to be naked, right? It can also impact our ability to have easy arousal or have easy orgasm, and unfortunately also lower that libido. And so one of my favorite parts of my job is to see whoever's sitting in front of me and take that big picture, right? I am not going to take you off your life-saving medication from your migraine, right? That's going to keep you from having pain. But absolutely, I'm going to see, is there a way that I can make a change? Or is there a way that I can add something in? But also to encourage the person sitting in front of me, much like Dr. Starling tries one thing and says, please come back, right? We will try one thing. And then if we try multiple things and we're just unfortunately working against a medication that has a lot of other benefits, might we turn to the neurologist or the headache specialist and say, hey, could we maybe try something else? And so doing that together with my patient and empowering my patient in front of me to say, please, I would love nothing more than to have every single clinician you see ask about your sexual health. It is my vendetta and my goal in my life to make that more of a possibility. But unfortunately, it falls on the person, right? On you. And if it's important to you, then it should be important to your medical team. But unfortunately, sometimes that means bringing it up first and saying, hey, thank you for helping my headaches. Unfortunately, this is impacting another part of my life. Can we maybe look at another option?
Thank you, Dr. Sobel. And just in light of what you ended with, I'd like to ask you, can you give us a few more talking points on how patients can begin the conversation about sexual health and sexual dysfunction with their healthcare providers? Because it can be hard.
very hard, right? And I say this from a place of asking every person who walks in the room, and I get all the different faces, right? Some people are coming in for obvious sexual concerns, and some not at all. And I'll bring it up, and they'll look at me like, no one's ever asked me that before. That's the goal, right? To normalize it, to say, hey, what sexual concerns do you have today? Not do you have any, right? What? Because it's so common, unfortunately, especially in women. So when I think about that's how I bring it to the table for every patient, often that's because they've never heard it before from a doctor. So what I say, sadly, is that I want you to know that if you bring it up to your clinician and they look at you blankly or they say something that I'd love for them not to say, it might be because they have never been taught it, right? We are not taught sexual health in most of our training. Even gynecologists are not taught it, right? Many of us seek extra training to talk about it. And so just knowing that and being able to say, hi, I'm not sure if this is what you do, but I've noticed these concerns, right? This is impacting my partner. This is impacting me. This is impacting an important part of my life. I'd like to figure out if you aren't comfortable, if you don't know necessarily the next steps, might you be able to refer me to somebody who can? And the great part is there are sexual health doctors out there. The International Society for the Study of Women's Sexual Health, called ISSWSH, ISSWSH, they have a wonderful, lots and lots of resources for not only, right, where can I find a provider who does this work, but even what are other common things that I could be seeing or saying to my doctor to help normalize it for them. And I hope for all of you that your team says, absolutely, here's who can help you. But if not, know that there are resources out there for you. So just ask. And just unfortunately, whatever they say back, I'm hopeful it's positive and really reinforcing. If it's not, that has nothing to do with you, okay? Unfortunately, we are not always so good at giving information when we're never taught it.
Thank you, Dr. Sobel. And you also mentioned earlier how various medications can lead to sexual side effects. I wanted to loop in Dr. Starling into this as well. Dr. Starling, can you start by telling us how certain migraine therapies can have potential sexual side effects?
Yeah, for sure. So I think side effects to medications are so important for you to be very forthright with your clinicians about them. Because I always tell patients the best treatment option for you is the one you're going to use. And there are many, many people who, for whatever reason, and maybe as according to this panel, right, that maybe because of sexual health reasons may start discontinuing use of a medication, right? And so we want them to be on these medications to manage their migraine disease. So in the space of migraine prevention, where you're using a medication to reduce the frequency of your attacks, reduce the severity and the impact of the individual attacks, make them more amenable to as-needed treatment options. There are several. There's two kind of classes we have now. We have ones that are we call migraine non-specific, and there's ones that we call migraine specific. And what we mean by that is the ones that are migraine non-specific were developed initially for other conditions like anxiety, depression, blood pressure, and seizures, but we were found later in randomized controlled trials and good studies in individuals with migraine that they were also effective for migraine. So just because it's migraine non-specific doesn't mean it doesn't work for migraine. They do. They're based on clinical trials. And then there are also what we call migraine-specific treatment options that really are targeting this protein that's come up a couple times today, this CGRP protein. Those are the ones that we have available right now that are migraine-specific that reduce the activity of that protein. And the ones that are migraine-specific, because they are really designed for migraine, they seem to have less side effects than the migraine non-specific options. Doesn't mean, again, that the migraine non-specifics are not good options for certain patients, because sometimes the sedation that you get from a medication is helpful for your migraine, but also for your insomnia. Or the antidepressant and anti-anxiety is helpful for your anxiety and depression or mood symptoms and for your migraine. So there can be benefits of those migraine non-specific options as well. But some of the antidepressants can affect libido. They can affect dryness throughout your entire body, including in your genital areas. And then there are other anti-convulsant medications like topiramate that can also have that drying effect as well as an effect on mood. And then other medications that can expand that exercise intolerance that can also have an impact or impact your sleep as well. So again, those are all potential side effects that can occur with some of those migraine non-specific options. And currently the American Headache Society has put out a position statement to really prioritize those CGRP targeted treatment options, to have them considered as first line options, meaning they should be considered first line options that are available along with the other migraine non-specific options, so that if a clinician and the patient feel like this is the best medication for efficacy as well as reduced side effects, that we should be able to offer that to our patients without having to undergo something called step therapy, where you have to try and find ineffective multiple other therapies before you can get to that. So as an advocacy tip, the Safe Step Act had been introduced into the current Congress. So if you would like to reach out to your Congress people, and please ask them to support the Safe Step Act. And if they haven't yet co-sponsored it, you just ask them, can you please co-sponsor the Safe Step Act? And then you share your personal story.
Thank you so much. I feel like this conversation could go on for forever. I know we've hit our end time at 12:51 though, but I want to thank all four of you for your amazing background, for your amazing advice and clinical experiences that you've shared. This has been very eye-opening to me, both as a patient and as a clinician as well, but I feel a lot more empowered to go talk to my patients and my providers about these topics, so thank you.